Our next speaker is Dr. Tonya Bailey. She is the Chief Diversity Officer for Lansing Community College, which is just around the corner from here. And she's going to be talking to us today about implicit bias and courageous conversations. Courageous conversations that are necessary to remediate implicit bias and bring true systemic change. Please welcome Dr. Tonya Bailey.
Well, hey, everybody, this is Dr. Tonya Bailey, and this is our time to have a courageous conversation. Yes, I'm excited to talk about implicit bias here at this amazing conference. Thank you so much for the warm introduction. I am so overwhelmed and excited to share this time with you. We're going to get ready to share my screen, and as I do, I want you to lock in, get ready. This is a type of information that we'll be sharing that's really important to the success, particularly in our health industry, but also to our society. We're talking about achieving health equity through growth, innovation, and reflection. And we're going to do that by highlighting the importance of courageous conversations surrounding our knowledge on implicit bias. So get ready to lock in and let's go. Again, I'm Dr. Tonya Bailey. I'm the Chief Diversity Officer at Lansing Community College. So today, I want us to have an opportunity to talk a little bit about how we get to this place of implicit bias, right? As I advance my slides here. So first, before I begin with anything, I have to thank you. Yes, the attendees, the champions, as I like to call you, for being our heroes, for being resilient, for being brave, and also for making the difference. Our community is inundated with thanks to you from institutions like Olivet, Lansing Community College, you name it, not only in education, but in our medical fields. You are making the difference day in and day out. And if you haven't been told thank you in a long time, here it is from me, from all of us. Thank you for what you do. It's important. I never start a session without having a type of wellness or welcome check because we are living still in a pandemic. There's lots happening with us. So I want you to tell me right in the chat, yes, participate with me. Tell me how you are doing. Really, I know we can give the quick fast, oh, I'm okay, things are fine. No, I want to know how you're doing. And while you're doing that, tell me who you are. So if I'm writing in the chat, I would say, I'm Tonya, and I'm busy good, and I'm from Flint. So please give me an opportunity to get a wellness check on you. Put it right there in the chat. I see you all putting it in there now. Give me a wellness check on where you are, where you're coming in from, how you're doing, maybe identify what type of profession that you're in today. Oftentimes, I like to do this when we're gathering, whether virtually or opportunities for in person, to just check on one of us. Don't have to be a doctor to do that. I also want us to start this conversation with what I call touchstones and hashtags adopted from Palmer Parker. I want you to use your chat function once again to tell me how you're going to be entering this space. It's very important for us to have common ground. These touchstones will help us as we talk about sensitive issues and uncover some uncomfortable conversations. One, you may want to put in the chat that you're going to be present as fully as possible. If that's the case, hashtag stay woke. Maybe you want to put attend to your own inner teacher. That's great too. You would put hashtag self-reflection. Or maybe you want to go with always invitation, never invasion. Then you'll put hashtag invite. Other hashtags here are trust and learn from silence. Hashtag silence is golden. Go ahead and pick which one of these hashtags is going to guide you, because as we go through this conversation, I want you to have something that's going to ground you. And this is important for our conversation pieces and even tidbits on what you can do when you're starting to have courageous conversations around sensitive issues. Just a few more housekeeping messages. Even though we'll have some Q&A at the end, I want us at this time to refrain from checking our emails and our phones and all of that. I know I'm probably getting 100 emails right now. now, but I want you to really lean in. Yes, lean into your computer, lean into your tablet, whatever you got, and really lean into the message of this session. Really lean into the information, as I believe it's going to help us all become greater. There are no observers here. Everybody's participating. So when we have options for chat functions or emojis, please use them. And I also like to say that, even though this might be recorded, what happens here stays here. But what is learned here must leave here. And if you're like me, I'm a crybaby, you got to have some tissue, or the time of the year for you when you have hot flashes like me, go ahead and bring your fan on in and do that too. All right, so let's get into this conversation about courageous conversations around implicit bias. I love this graphic right here because it really just says it all. Have you considered unconscious bias training? And it's really designed to get us thinking about what are some of the things that we really need to focus on in healthcare in order to be effective in that healthcare. Well, there's a video that I'm going to show you right now that kind of opens up the idea of where unconscious bias come from and understanding that we all have it. So we're going to take a few seconds to watch this 2-minute video, and I'll be right back after this.
The unconscious mind is amazing. It can process vastly more information than our conscious mind by using shortcuts based on our background, cultural environment, and personal experiences to make almost instantaneous decisions about everything around us. The snag is, it's wrong quite a lot of the time, especially on matters that need rational thinking. Here's a classic example. A bat and a ball cost £1 10 If the bat costs £1 more than the ball, how much does the ball cost? Most people, including over 50% of students at some of the world's leading universities, get the answer wrong and say 10 pence. The answer is actually 5 pence. Many of us choose 10 pence without thinking. This is because our unconscious mind uses instinct, not analysis. So our unconscious is fallible. It's also biased. It makes snap judgments of people we meet, categorizing them according to gender, social and other characteristics. In milliseconds, we judge whether somebody is like us and belongs to our in-group. These are the people we favor. So men might favor men, while women might favor women. However, we can belong to different in-groups, and we like to be part of an in-group that's powerful, which could mean a woman favoring a man over a woman. That's unconscious bias. All of us have it, and it colors our decisions without our realizing. For example, research reveals that if I were a man, you would be more likely to be nodding in agreement right now because people pay more attention to a male voice. The Royal Society fosters excellence in science, but this can only be achieved if we select from the widest range of talent. And that's not possible if unconscious bias is narrowing down the field for non-scientific reasons. To lessen the impact of unconscious bias, which is easier for us to notice in others, we are raising the awareness of unconscious bias to members of our selection and appointment panels. We're encouraging panel members to deliberately slow down decision-making, reconsider reasons for decisions, question cultural stereotypes, and monitor each other for unconscious bias. We can't cure unconscious bias, but with self-awareness, we can address it.
And so you just watched a video by the Royal Society talking about what unconscious bias is. And I hope you got right into the understanding that we all have bias. We all have, and I'm going to explain a little bit more as we go forward. But as we take this opportunity and many more to have courageous conversations about this, I want you to understand that this is about having human conversations. It's about us being personal in our endeavors to change, not just ourselves, but our community, our organizations. And it's about us having the ability to sit together virtually or in person, large groups, small groups, one-to-one, even over dinner, as that may be the case, to talk about things that might be uncomfortable, but definitely need to be courageously discussed. And so that's because we all have unconscious bias. Well, what is bias? I'm so glad you asked. Bias is defined as the negative evaluation of one group or its members relative to another. It's simply a negative evaluation that we have unconsciously and sometimes consciously. Explicit bias, though, requires that a person is aware of his evaluation. Like, I know I don't like fat rounded tires on cars, right? For example, but it's that evaluation that I am aware of it. And I believe that my evaluation is accurate. So because I don't like fat rounded tires on those type of cars, I believe that everybody should feel like they're ugly as well. Maybe not a great example, but you get my point. Bias is something that we might be aware of when we talk about unconscious bias in contrast to implicit bias, because it doesn't require the individual to be aware of what the evaluation is to a certain group, but it also operates unintentionally or unconsciously that I feel this way. And this is why it's important for us to discuss what unconscious bias is in healthcare then. So understanding those 2 or 3 definitions gets us to the third. In healthcare, implicit bias can shape the way medical providers interact with patients. It's known fact, because everyone is susceptible to implicit bias. That's right, you, me, everybody, even clinicians. These unconscious perceptions will naturally seep into patient-provider communication, and it has been proven time and time again. Here's an example for us to look at. Implicit bias can show itself in conversations with doctors that are treating Medicaid patients. I have even heard that Medicaid patients have been termed Medicaid queens. Have you ever heard of that? Put yes or no in the chat. Yes or no in the chat. Let's see if you've heard of that term before. It's otherwise using a language that can suggest that the patient is somehow someone that's less than. Implicit bias, therefore, can show or shape its tone with that clinician that speaks to that patient in that way if they feel like this is a Medicaid queen in a content of that conversation. It can also erode in the type of testings that's given or even referrals. So if a clinician, if a profession in healthcare member is diagnosing or engaging with a patient and they have implicit bias about whether their insurance said Medicaid or they have no insurance, instantly there can be some biases that arise in us that have been there unbeknownst to us, and it affect or influence how we treat, how we communicate, how we refer, and how we engage with that patient. I want you to pause and just kind of think about that as I go to our next slide. Perhaps we can talk about this. Did you know in the study of medicine back in 2003, they concluded that unrecognized or unknown biases among members of certain social demographics may affect the communication and care that they receive. They found that this caused a lot of effort to reduce healthcare disparities. They were looking at healthcare professionals and trying to find out how can these implicit biases affect the care that vulnerable populations are receiving. And vulnerable populations that we're talking about are minority ethnic populations, right? Immigrants, poor, low health literacy individuals, sexual minorities, children, women, elderly, mentally ill, overweight, right? Or even the disabled. And so as we think about this, we have to also think about knowing that we have these types of biases, what are some of the consequences that will happen, right? With some things, what are the fallouts as a result? As with any interaction, implicit bias can have adverse effects on the patient experience. Let's talk about that. By damaging patient-provider interactions, implicit bias can adversely impact health. Now, I know all of us got into this field that are part of the healthcare community because we wanted to serve, because we believe in research, because we believe in medicine, we believe in being helpers and healers and all of the things that I accoladed you about at the beginning of this, heroes and so much more. That's great. But I want you to think about for a second of some of the consequences that have occurred. Patients can feel less inclined to even engage deeply with health, with their own care when they are experiencing implicit bias from their healthcare providers. Interesting. Patients can also be kind of dissuaded from even visiting their provider. We know that there has been historic instances, for example, with the Tuskegee experiment. We know that particularly Black and Brown communities have some trust issues when it comes to healthcare communities, and providing examples of them being in implicit bias interactions doesn't help. Also, consequent is that the patient may have a lack of not only trust, but they may put a cap on their understanding of their own health, which is dangerous, right? So if I won't interact with you because I don't trust you, or because I feel as if I'm not being valued, or I might be experiencing some microaggressions, and we're going to talk about that in a second, I won't even be able to engage educationally about my health. I know individuals who refuse to go to the doctors because they don't trust doctors. I know individuals who refuse to even get the vaccination because they just don't trust it. There is such a lot of opportunity for us to mitigate implicit bias so that we help patients understand their care, we engage them so that they have more insight on how well they can be and receive the best care from some of the best of the best. That's you. So I want us to think about the consequences that come from us operating in implicit bias, particularly in our healthcare. But to do that, I want to go us back down memory lane. Look at these cute kids, right? At some point, we all were like this, young, free, excited, didn't care, but we didn't know that at very young ages, the origins of bias began to have demonstrating insights into our own lives as early as 3 years old. Just put the number 3. Just put the number 3 in the chat for me. 3, 3, 3, 3. It's interesting. I mentioned before I'm a mother of 8, and to see that implicit bias could have been embedded into my children's life at the age of 3. You're thinking, what can a 3-year-old do? But this is how it shows up. And conscious bias begins to show up through the media, what they watch, even the materials. I used to buy my kids these materials to write their letters and all of that, and they would have, unbeknownst to them, levels of bias on the type of characters that they would use, whether they would look more like brown people or look more like Caucasian people, or not have the diversity there. Those messagings are set in. We also know about the baby doll experiment that has been done way back in the 60s to identify with students or young adults, children, how they felt about their own perceptions looking at dolls. And many students of color selected dolls that looked Caucasian as nice and sweet, and identified dolls of other ethnicities as being mean or angry or bad. Those types of imaging and messaging where they have been exposed to, unbeknownst to parents, not having opportunity for diversity, not seeing other styles of lives or perspectives at the early age. All of this has been built in since the age of 3. Now, I won't ask you your age. I won't dare tell you to put that in the chat, but I will say, isn't that amazing how the origins of bias, both consciously being shown up at the age of 5, negative bias stands to quiet down around 10 to 12 because they're starting to come into their own identity and they begin to find a sense of fairness. I just want to get along. And then negative bias grows stronger and stronger as it is normalized. So it's important for us to understand where that comes from, but also what is the difference between explicit and implicit bias. So I like to use this diagram because I think it does a great job. And it also reminds me of one of my favorite movies, the Titanic. Okay, so you know the Titanic sank because of an iceberg and so many other factors. But what the ship captain did not see was the things at the bottom of the iceberg, which is the implicit bias, if you will. That is the unconscious attitudes that we have that's below the surface, may not be influencing of our behaviors, may not even be aware of us. But the explicit is what's at the top of the iceberg. It's those attitudes and those beliefs that we have about a certain person or certain group. Or I don't believe in same-sex marriages, or I don't believe in integrating with different communities, explicitly, things that we can see at the top of the iceberg versus things that we can't see at the bottom of the iceberg. Does that make a good sense for you? To give you a better picture of the line of consciousness? And so when we really break it down, the thoughts and feelings are implicit, meaning everybody can see it, even if we are unaware of them or mistaken about their nature. We all have a bias when, whether being neutral, we have a preference for, or we are adverse to a person or a group. Thus, the term implicit bias is to describe how we have attitudes towards people, associations, our stereotypes with them, without our conscious knowledge. A fair commonplace example of this is seen in studies that show that white people were frequently associated with criminally with Black people without even realizing they're doing it. And so I want you to have this understanding in your toolkit and further give a side-by-side example between explicit bias and implicit bias, because this is going to come in handy for us as we work through the rest of this conversation and begin to work toward how we have courageous conversations around them. Thank you for being in this conversation again. So again, explicit bias is something that is expressed directly. Again, we can see it, top of the iceberg, right? It's aware of the biases. You're operating consciously that I have this bias. An example might be the sign-in window of an apartment building says, we don't want to rent to people with dogs, or dogs are not allowed, or that's explicit. No dogs allowed here. Implicit bias example, a property manager doing more criminal background checks on African Americans or other ethnicity groups than whites. Well, the background check is gonna take about another week longer for you. Well, they just told a couple right in front of them, we'll have this background check to you in one day. Just making those distinct instances of biases, and sometimes unaware, but our biases nonetheless is showing. So let's play a little game. I love it. Time to play explicit or implicit, because you know I'm a teacher too. I got to find out if you're paying attention to all of this. So in the chat, I want you to respond to these examples. Okay, ready? Here we go. Example 1. The department head and/or supervisor is making a homophobic or sexist joke. Is this explicit or implicit? Write in the chat, E or I. Make the letter E or I. Now let's go to the next example. The supervising medical staff making negative comments about African Americans or Black patients. Is this explicit bias being shown or implicit bias? Do an E or I. Okay, here's number 3. Thanks for participating. I see you guys doing it. Differential treatment recommendations for pain medications for people of color. Is this explicit or implicit bias? Put an E or I in the chat. Got a few more to go. You ready? Here's another example. Predominantly male committee unconsciously using different subjective measures to evaluate promotion or tenure for females. Is that explicit or implicit bias? We're testing our knowledge today. All right, a few more, let's roll through them. A white physician retaining more distance from patients of color. Explicit or implicit? E or I? I'm gonna roll through these next 2. Ignoring the sexual orientation and family status of your lesbian, gay, bisexual, transgender, queer, questioning, or intersex colleague so as not to be rude. Is that explicit or is that implicit? Last one, a physician not taking full sexual history for a married man and ignoring the potential he may be a man having sex with other men. Is this explicit or implicit? I'm gonna share all of the correct answers with you at the end of this presentation, but I wanted you to begin to think about just some of those actions and those thoughts through these examples. Kudos to you for participating. So I want us to think about the extensive research that has been done on physicians with verbal and nonverbal behaviors, as well as with patients. There's tons of research out there, and I want to engage you to start looking at that. So take a moment, get yourself a phone out, and take a quick picture of this slide. you're allowed. I want you to do that so that you can start educating yourself on various research that's been done, particularly in your field, on how research has found implicit bias as well as strategies to avoid it. Because we know it's been shown that they can lead to avoid healthcare and impair communications, as well as challenges, as well as find out innovative strategies to address this. So I want to give you that. Have you taken your selfie yet? Was I in the picture? Okay, here we go. Again, implicit bias is increased by stress. We make rash decisions when we're stressful. And in our field, this healthcare field, every day can be an element or elements of different stress. So we have to recognize our implicit bias because it can creep up just with stress. A lot of people called off today. So now we're short-staffed. I know everybody can relate to that, right? And so that increases stress. Or maybe even before you got to your set time of work because you have many things going on, you're stressed about that pre-job work, time pressure, multitasking. I've got to handle this and I got to handle that. A lack of clear criteria in the decision making. Maybe your environment have not established, here are what we do in this situation and that situation, right? When that's not outlined, it really does increase your implicit bias. Also, being ambiguous about or incomplete information, not having enough. What do I do in this situation? Not asking enough information about what you don't know of. And the lack of familiarity with people from various groups. All of these things increase implicit bias. Implicit bias, though, is not increased or is not decreased by good intentions. Well, I think I'm a good person, right? I think I'm pretty decent person. I'm likable, right? That's the kind of things we tend to hear people say. It's not decreased by that because you have good intentions. It's not decreased by someone who is telling you to reduce your bias. Go ahead, girl, just reduce your bias. How does that happen, right? No, it's not decreased by that. It's not decreased by suppressing the bias. Well, I know I have it, so I'll just avoid going around that group of people. I'll just avoid doing this or that. That's not how we address or combat implicit bias. It's not decreased by avoiding people from other groups or thinking you don't have it. I want you to have a confession moment with me. Raise your right hand. Say with me, I have bias. Diagnose yourself right here. I have bias. Put it in the chat. I have bias. It doesn't matter if you're degreed. It doesn't matter what race you are. We all have bias. Thank you for making that pledge of acknowledgement with me. Notice, both hands were up. Okay, here we go. Why is all of this important? Well, we know when we watch the video, we understand that now we all have biases and that our actions really occur about our conscious thoughts. It allows us to function in extraordinary complex world and ways. That means that however that our implicit bias often predict how we'll behave more accurately than our conscious values. And so having this discussion, you being here today, right, at this amazing, amazing conference is proof positive that you want to grow and you see this as being important. And I know that not often has this been a comfortable conversation, but it is a necessary conversation. So what can be done about it? So glad you asked. We know that social sciences are at the early stages of determining how to de-bias. I'm going to share with you some strategies and tips as we go along the way that will help with that. And so I want to make sure you still got your pens and papers handy for that information. But it's important that we understand that specifically addressing how our mind is at risk of implicit bias, that we can no longer avoid acting as if biases don't exist. I don't have it. We just took the pledge. We do have it. Implicit bias is a universal phenomenon. It's not limited by race. It's not limited by gender. It's not limited by the country or origin that you come from. It's not limited because you have this amount in the bank or that amount in the bank or no bank at all. It's universal. And together we can address it. To do that, I think we need to understand a few key definitions about diversity, equity, and inclusion. Are you ready? This is a great another selfie time to take up the screen, especially if you are really wanting to lean into this information. So diversity is being, as Verna Myers would say, invited to the party. Equity is about ensuring everyone has appropriate transportation to dance, regardless of their starting location. And then inclusion is being asked to dance once you get there. You know, this before the pandemic, the industry of healthcare was skirting around issues of health equity and health disparities, and evidence was starting to merge that health inequities were leading to large gaps in our care and access industry, right? And so understanding these concepts is extremely important for understanding social determinants of health, which also allows stakeholders to really take a proactive measure in achieving value-based care. But we could not do this or have this attention and forget that racial health disparities is just as important a part of this conversation as ever before, especially now that we have experienced the COVID-19 pandemic. It has come to highlight the various disparities with Black and Brown, Hispanic, American Indian, and Alaskan Native, Asian communities who have severely been impacted by this whole pandemic, right? And so having understanding now that diversity is about all of us and our collective differences and our collective spaces, that we come from a variety of different instances, and that all of that showing up at our job or showing up as patients or showing up in our community does matter, because diversity looks at who exactly is in the room, right? And equity is recognizing that this person comes with Medicaid, this person comes with no aid, this person comes with a lot of aid. How all of those factors, this person comes with multiple intersectionalities and differences than your own. It's important that we look at how we are distributing resources to those equitably, and how are we including them in our case management and the way that we go about our practices. Does that make sense? Did you get your selfie about this particular slide? If not, we're going to ask for more. Just a second. So to further break this down, because I know there's been conversation, well, I thought equity was equality. No, there's a difference. Equality is about giving everyone the same, right? But equity is about giving everyone the resources that's specific to their needs. If a person, as you look at this diagram, needs more of a smaller bike, then they are given that bike that meets their size. If they're in need of a type of cycle that helps with their abilities or enable issues, then that's what they should have. The second person at the top there, on the equality, he's hunched over. This bike is not his size. But when he comes to the equity side, he's able to get the bike that is good for his back and good for his size, and he's able to ride on. That's what we have to identify as health practitioners. One more thing about diversity, equity, and inclusion. Again, we have to understand that folks in our worlds that come in for services, we have to understand that they're coming from diverse places. And we have to look at who's in the room, who's in the meetings, who's a part of the committee that you have been assigned to, who's on your staff, how diverse is your staff, what type of diversity rests there. In terms of inclusion, how does everyone in the room engage or feel even being there? I know as a person of color, a Black woman, there's no meeting that I don't go into that I don't recognize who I am and who is not or like me in the room. It's called the look. We do that as well. We look to see who is like us, and that really makes a difference. It's a level of sense of belonging. It's a level whether my voice will be heard, whether I will be valued. In addition, we look at equity, who is looking at the decision makers. Who's making the decisions? Is it those that are of the top echelon, or those that got the degrees and we don't hear anything from those that didn't? How do we determine determine the policies, the practices, and procedures based off of DEI. Well, I want you to begin to think about this and have that in your mind as you relate this to the workspace that you are a part of, and seeing how we can better examine provider bias in healthcare. So I want to give you just a brief study. I'm going to read this for you and then have you think about what will happen. So we know that providers are often faced with the need to make complicated judgments very quickly, and also sometimes to do that with insufficient or imperfect information. And so they have to rely on assumptions associated with the patient's social categories to fill in gaps and all of that good stuff. We know that. And that also makes physicians at a higher risk for relying on stereotypes, also biases, and so much more. And so I want to read this case study to you, and I want you to be thinking about how you would respond in this situation. Here it goes. In 2015, a 27-year-old patient presented to our primary care resident practice in an intractable pain, in very severe pain, having recently been discharged from the hospital following surgery for a complex surgery or fracture, shoulder fracture. The orthopedic surgeons evaluated him the day before and scheduled surgery, but did not adequately treat his pain. The inpatient nurse had told him that he would be discharged with the oral pain regimen, and he had been taking for the past day. And so within the hospital, she was going to follow that process for him. But upon discharge, he found himself without those prescriptions and came to the primary care in severe pain. When we review his inpatient record to determine the reason for his discrepancy, the attendee physician discovered the phrase drug seeking in the record. The rationale for this statement was not provided, nor the context. When questioned by his new primary care provider about this, the patient was shocked. He tried to recollect what he may have said to them that may have resulted in this assumption. He had no prior history of documented substance or prescription abuse. The patient in question was a young Black male, the victim of a drive-by shooting by a stranger. He had been sitting in a passenger seat on a stationary car when the incident happened. And the standard practice in this type of case involves, long-acting oral opiate medication with gradual adjustments of a medication regimen tailored to meet the needs of the patient. But the patient did not receive the standard care and naturally wondered why. What would be your response to this? Make a great, maybe 2-3 line comment in the chat, and we will review those at the end when our question and answering period occurs. All right? So in addressing implicit bias, I think it's important for us to look at how we can come about being more proactive. Eliminating bias is a challenging task. Let's just be honest. No one's implicit bias is something that most people are aware of or is not really purposeful. But we can have purposeful discrimination, which is referred to as explicit. So one of the things that I would like to recommend is that we have a strong educational campaign that can be our first good step, like this conference here, making sure clinicians pick up on their own biases and learning how they can mitigate those in adverse situations and their daily work. We can also use cultural competence and cultural humility training to help providers acknowledge their own biases and then also be educated on other cultures so that they can be more aware as well as informed. Third, organizations should also look at communities that they serve. If your clinic, hospital, office is in a rural community or in a space where most of your clientele don't look like the providers that's there, those are opportunities to do outside outreach, mobile mobile medical care, and so much more in order to get to know that community, making sure that that trust is being built, as we talked about, and being repaired along the way. These are just a couple of examples for that. Also, I think it's important that we look at strategies that consciously have us thinking about the patient's perspective. I know we have a regimen and a line and task that we have to make sure we complete, but not forgetting the patient's perspective is key to mitigating bias. Approaching each provider-patient interaction as a shared integration, right? A shared worldview, focusing on specific unique details about the individual. Also making sure that everyone is up to date in training, and not that it's a grudge, but it is an opportunity for learning. Literally priming physicians and others with information about relevance or irrelevance of social culture factors that tend to sway medical decisions and referrals. Those are important pieces. I also want to provide something called bias racism rounds. This is something that can be done even in our teaching hospitals, and even in the regular routine of hospital walking and checking in on patients. Let me give you some examples of that, how that might look. So IBR, or implicit bias round, could be where the doctors and nurses are walking through the cases that they have and looking at inadequate pain treatment, as in the idea of the example case study that I provided before, discussing events that led the staff to correct this error would be what could be done, having those conversations in like a case study discussion, performing a thought exercise. Well, what if we thought about this? Have we thought about that? Have we considered this type of exercise to get people thinking outside the box and more patient perspective? Also thinking about discussing about the literature, about race and ethnic disparities, not ignoring it. This is a Black patient. This is a Hispanic patient. This is an indigenous patient. We have to have those conversations because all of those factors matter. I know every time that I've been into my physician's presence, they ask, do you have a family history of XYZ, right? Because we're trying to understand a case and identify what things on the spectrum might be causing a present issue. Having those case discussions is essential. And then determining, when we make an error, how should we discuss it with the patient? Understanding, we know that there are malpractice issues and suits, and sometimes like, we don't want to talk about it, but really being transparent and having the discussions with the patient that, you know what, we missed a step here and we're going to rectify it by giving this treatment or giving that treatment. And discussing what are our follow-up information. How is the patient doing now? What has been corrected or advanced since our understanding? Because, you know, at the end of the day, our best intentions won't solve implicit bias in healthcare. I know we all encounter new patients and new situations, and that can imprint on our mind or raise up levels of biases. And we can all have good intent, but without the impact of really going after biases, we really won't have a fighting chance. That's why I'm encouraging all of you to take the implicit association bias test by Harvard. You'll find information about that at the end of this presentation, but these types of questions help us to understand where our bias lie and what things we can start watching out for. It's also a good idea to look at Project Impact, which stands for Improving Medicine's Power to Address Care and Treatment. This is a global effort to reduce disparities, and I appreciate the work that they're doing. They have identified that for more than 1/3 of healthcare quality measures, Hispanic patients receive worse care than white patients. Their studies have found that Black American, Indian, Alaskan, Native patients receive worse care on a 40% quality measure than their white counterparts. These are all things that we can address and stop hiding our heads in the sand, because the conversation that we've probably been avoiding all this time is really a leadership opportunity. Go ahead and put in the chat, leadership. Come on, write that right now. You're here today because you're a leader. You're here today because you have an opportunity. And I want to talk these last few moments about how we have this conversation around implicit bias as relates to having it in a courageous way. To do that, I want to recognize that the obviouses are happening around us. We see microaggressions happening. We see people asking others, where are you from, really? I got a wonderful video clip. If we have time, we'll be able to show that as a part of this. Or maybe someone that has, as a part of our transgender and have been told, you'll never be a real woman. I want you to think about these types of microaggressions because they often are a part of our daily lives, not only just with patients, but even with your coworkers. And having these types of blind spots, hidden biases can easily guide our behavior without us even being aware of. And so I want us to begin to think about all of those different things. In fact, I want you to think about this question. Can you look back and think on a time when your actions was influenced by a bias that was previously unconscious? Go ahead, put yes or no in the chat. And there is no judgment here. Remember, our touch tones are coming through right now. So go ahead. Can you think of a time when your actions were influenced by a bias that was previously unconscious? Go ahead and do this in the chat and just take a moment to do what your response is in this area that's presented itself for us today. As you do that, I would like to talk to you in our final moments about having courageous conversations that are not about calling out, but more about calling in. We've all experienced a calling out culture, which has the tendency to be progressive toward radicals and activists and community focused individuals. People can be called out for their statements or called out for their actions. Hey, that was sexist. Hey, that was racist. Hey, blah, blah, blah. The list goes on and on. But because call out culture tends to be public, it can also be damaging. It can also have negative impacts. And so I like to subscribe to more of a calling in. And so when you think about a time that maybe someone said something to someone, to some aspect of your identity, female, culture, race, maybe you felt it was intentional or unintentional or dismissive, insulting, whatever it was. I want you to think about that for a minute. Think about what was said. Think about how that made you feel. And how did you respond to what was said? And how did that feeling or what happened afterward? For me, I was asked in my undergraduate first year college, freshman, by my Caucasian roommate who was from a rural community. She asked me, I can't stand it, I just gotta know. She says, are you Black all over? Now I'm from Flint, tough city, right? And I'm in Indiana at a school, and I'm being asked this for the first time. When she said it, instantly, yes, I got angered. It made me feel devalued. But what I responded was from what my mama taught me. So thank God for my mama. Goodness for my mama. She always says every situation is a teaching or learning situation. You choose. I chose that this was going to be a teaching situation. So I said to her, yeah, that long as I've looked, I'm the same color all over. Tell me about where you're from that would make you ask that. Is this your first time being around a person of color? And the conversation went and the conversation grew and it was very refreshing. And I got a chance to see it wasn't being intentional, trying to be hurtful. She just really didn't know. And not having that exposure, now she got the Tonya Bailey experience. I want you to think about that because our reactions to things can either be teaching or learning, but also help us to understand where individuals are. Ultimately, we know that calling out culture can end up mirroring what like the prison industry complex teaches us about crime and punishment, to banish, dispose, and get rid of people and stories. Calling in, though, however, is a practice of loving each other enough to allow them to make mistakes. Yes, I said it. The practice of loving ourselves enough to know that we're all here trying to learn and unlearn things that needs to to happen, especially around implicit bias. Here's a couple of things that I think might be helpful. Number one, decide on some ground rules when you get ready to have a courageous conversation. Just as I started out before, I gave you ground rules about our touch tones and hashtags. I talked about what would be allowed and what would not be allowed. I encourage you to lean in when you're having courageous conversation. This is for the CEOs. This is for the department heads. This is for those that are just having small group discussions, or even with your family and friends. Think about what the ground rules will be, what is going to be expected. Secondly, listen actively. And I should have wrote on here, listen, not reload, okay? Because oftentimes we're listening, but we're also trying to reload as we listen. I don't want you to do that. I want you to listen actively. That means listening and trying to understand the other person's perspective and asking clarifying questions like, what did you mean? Or did I get this right? You said blah, blah, blah. Number three, communicate to be understood, not to be right. Communicate to be understood, not to be right. It's so important that you don't do grandstanding. Well, I'm saying this and I'm putting my foot down and that's what it means. You might be wrong, but I want to communicate so you understand my position. You understand my culture. You understand my opportunity in this conversation, right? Calling in even on issues of microaggressions means that we have to speak up without tearing down. Yes, speak up without tearing down. And I said it again, that's done with love. That's done with compassion. That's done through asking questions. That's done through agreements between the individuals working together to have this courageous conversation. So here are key phrases. I know you're going to want to take a selfie of this. I'm going to let you get your phone out right now. Please capture this. This is how to start a call-in courageous conversation, right? So you've made the ground rules work. We're talking about, let's just say race, or we're talking about bias in the workplace, right? When that discussion is happening, instead of going, whoa, no, you're wrong, and being accusatory, try these phrases. One, I need to stop you there because something you just said is not accurate. That's different from saying, that's not right, you don't know what you're talking about. I need to stop you there because something you just said is not accurate. Two, this is my favorite, by the way. I'm having a reaction to that comment. Let's go back for a minute and then explain from there what that reaction that you're having or discomfort. Number three, do you think you would say that if someone from that group was with us in this room? Especially, we're going back to that testing that implicit bias, right? That quiz, and someone is making a joke or being insensitive or microaggressing. Say to that person, do you think you would say that if that person was standing around this group in this room? Fourth, there's some history behind that expression that you just used that you might not know about, especially if you have inside information. That's a great phrase to use. Here's one more. In this class or in this workplace, we hold each other accountable. So we need to talk about why that joke isn't funny. That's a stellar one for the workplace, especially for leaders and CEOs of company and those that are particularly in the healthcare career. I want you to take a selfie of that because you can put those phrases right in your back pocket, put it right on your tab when you get ready to go into the meeting, and be ready to have the call-in conversation tips. In addition, I know that reframing bias can be manageable. We can do this, but we're going to have to break certain habits. We got to raise awareness of our own biases. We got to have understanding of the consequences of bias, as we talked before. We got to recognize that when bias responses may occur, we have to be ready with our responses to mitigate that. We got to replace bias responses with responses that reflect non-prejudice goals, right? Stereotype replacement is a must. We got to counter stereotypic imaging. Maybe we don't have enough people of color in our brochures and our care patient statements. Maybe they haven't been translated into other languages so that others from different backgrounds can read them. Maybe we need to do those types of counter stereotyping images, individual conversations and understanding. Perspective taking is so key. be, and then being increased opportunities for contact, not just waiting for folks to come to us, but we're going to them. Understanding that the roles that we have to create as healthcare professionals and just as great humans is that we've got to go through this cycle of from being bystander to receiving, to being a receiver, to moving into action, and ultimately becoming upstanders. If you will, in the chat, hashtag upstander. An upstander is one that is not going to stand by, not just going to receive the information, not just going to act on it, but is going to be a promoter of all of these things going forward. Isn't that great? Our intent versus impact has got to be what matters the most. No matter the intent, we always have to strive for impact. When we respond to microaggressions, there are 7 options that you can use. Education, obviously, assuming good intent, humor, yes, I love it. Question, personalize it for you. Fall back on rules and policies in the reflect that, well, this is just our standards. Well, maybe our policies and procedures have been influenced racially and have racial systemic barriers. We need to address those, evaluate those, and fall back to reassess to move forward. Be direct and don't stand by at all, but be an ally or an upstander. So we know racism exists. I live by the notion that race is a construct that can be deconstructed even in healthcare. So in these last slides, I want you to do this. I want you to start getting into good and necessary trouble. As Senator John Lewis taught us. 1, be courageous. Examine who's in your network. Start looking at who needs to be more part of our organizational practices and procedures. Remember, diversity asks who's in the room, right? Or who's trying to get in the room. Be bold. You have an opportunity to use your education, your influence, your privilege, if you will, to allow others to have a voice, to have care, and to have accessibility to effective healthcare for them. And as a community, I must beg us all to be forgiving. It's so important. Normally when I start my trainings, I always do something that I call being real, which says, I'm gonna ask you at the beginning to forgive me and everyone in this room for obvious reasons, what things I may say or do and may not know that it offends you. Start forgiving. A lot of times, particularly people from non-ethnic communities, they're fearful to say anything. Like, I don't know what to say. I don't want to make a mistake, so I don't want to say anything. I've heard that time and time again. We have to be forgiving, as well as one Black person can't represent the whole Black race either. We have to be forgiving and understanding and assume positive intent of all. Lastly, we have to be brave enough. I personally live by the motto, I can, I will, I must. I want you to share that in the chat as well. I can, I will, I must. Just type that. It feels good typing it because I can mitigate bias. I will mitigate my own bias. I must mitigate my own bias. We see this type of bravery even have happened in Starbucks in their recent debacle, when they had a lot of microaggressions, stereotypes, and definitely implicit and explicit bias happening against 2 customers. They now have become more brave and have started to close their shop early and have conversations across the nations at their stations about this discussion. They're courageously having it. Maybe you need to do that in your group, in your department or division, to close up shop or to add it as a part of your agenda item, and making sure that this is how we're going to practice. Not like this wheelbarrow here with all the resources at the top, and we're using old areas to address new challenges. We have to be brave enough to dismantle systemic barriers in healthcare, systemic barriers, period. And we got to reevaluate where we stand right now. Does this picture kind of look like how we've been operating? And if so, what do we need to do to change it? How do we move forward? Are we looking at our patients from this vantage point? Well, hey, I went to school and I was educated. I don't understand why you can't do the same. And maybe you're a person overweight and I'm a person that's really big on fitness. I'm judging and biasing how I treat you based on how I feel in my life. What does it matter? This graph says it's all the same, but it's not, because each of us come to the race with various different obstacles, and especially people of color. They're juggling, they're battling long before the guy says, run her to your mark, except go. Long before that happens, they have this all in front of them. Seeing people from their own perspectives helps us to do that. Well, how can I do it? Become a part of an allyship posture. Read. There's so many books out there, many trainings such as these. Don't take it as a grudge that I got to for continuing ed, but I must to continue to educate myself. And I encourage you to do that. Lastly, I want us to think about crafting a new view. Instead of pouring knowledge into people's head that need to help them grind the new set of glasses and all that, I really want us to start thinking about the assumptions that have shaped the way we have historically looked at things. When I start thinking about how historically I thought about things since the age of 3, how influenced we've become as society, it helps me put on another set of lens and have courageous conversations.